أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين أما بعد الحمد لله we have fulfilled our Salatul Maghrib just like the Prophet Muhammad peace be upon him said As-salatu ala waqtiha, the best ibadah is to pray salah on its prescribed time. For our next plenary, I would like to introduce our moderator. She is a graduate of Doctor of Medicine from Our Lady of Fatima University. She had her residency training of obstetrics and gynecology residency at Zamboanga City Medical Center. And now, she's a fellow in different societies, including Philippine Obstetrical and Gynecological Society, Society of Gynecologic Oncologists of the Philippines, and Philippine Society of Cervical Pathology and Colposcopy at Philippine General Hospital. Currently, she's a medical specialist 3 and the head of the Gynecology, Oncology, and Colposcopy unit of Zamboanga City Medical Center. Also, she is the president of Philippine Obstetrics and Gynecology Society of Western Mindanao chapter. Help me welcome one of the best gyne onco in the Philippines, Dr. Jihada Inu Miswari Alihuddin.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Bismillahirrahmanirrahim. Alhamdulillah wassalatu wassalamu ala Rasulullahi wa ala alihi wa ashabihi ajma'in. Thank you very much, Zain, for that kind introduction. It is my pleasure to be your moderator for today's third and last, but definitely not the least day of our Virtual Islamic Medical Conference. Jazakumullahu khairan to our 338 strong ummas who stayed with us up to the last day. For this specific plenary, we will be tackling two topics. The first one is entitled Who Made Me? The Islamic Perspective of Assisted Reproductive Technology and Reproductive Genetic Testing. The second one will be Islamic Perspective on Abortion and Family Planning. For our first speaker, she is a fellow of Royal College of Obstetrician and Gynecologists in London, United Kingdom, and a fellow in vitro fertilization, reproductive endocrinology, and reproductive minimal invasive surgery in London, United Kingdom. She is also a reproductive genetics and epigenetic researcher at PGD Center, United Kingdom. Without further ado, I would like to welcome back on the virtual floor the most credible and fitting speaker to discuss on the Islamic perspective of assisted reproductive technology and reproductive genetic testing, Dr. Hanan Ali Sultan.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can I have my slide?
Salam, Doctor.
Yeah, next one, please. Bismillahir Rahmanir Rahim. Wassalatu wassalamu ala ashrafil mursaleen. I'd like to give everyone a warm welcome from Jeddah, the gate of the two holy mosques in Mecca and Medina. Next one, please. And it's really, I'd like to thank for the moderator for the nice introduction and also the organizing committee for inviting me to give this talk. I'm going to talk about the ART, introduce it, and the BGD, and then the bioethical views, followed by the Islamic perspective of these technology, and then the legalization of the ART and BGD worldwide, and particularly in Saudi, and then we will conclude. Next, please. For those who doesn't know what's the difference between IVF or what is meant by in vitro fertilization, especially I knew that we have some of our junior and future doctors in the audience. So normal fertilization occur in the tube after the ovulation occur, and then the embryos remains in the tube for about 5 days before it goes back and then goes in the endometrium. So the whole idea of the in vitro fertilization is that we do this step in the lab, in the dishes. Next, please. The first or the simplest assisted reproductive technology is either we do it in vivo or the in vitro one. The in vivo one is the intrauterine insemination. And here, what we normally do, we don't touch the eggs. The eggs remains inside. We only give plus or minus ovulation induction. This means that we induce the woman to have one egg, and then we trigger that with an injection. That so we time the ovulation, and then we prepare the sperms of the husband in the lab, and then we inject it through the vagina inside the uterus. Hopefully that she will be pregnant. And these like cases of minor male factor infertility, or if there is a cervical problem that we would like to overcome it. So these are an in vivo one. Next one, please. And then the in vitro one, which is the IVF-XC, and this was formed in 1978, then TZ and MESI, which is from the male, whether or plus or minus micro, then the BGS and the BGD, and I'm going to talk about this later. Next one, please. Next one. Thank you. So here the conventional IVF, as I said, the fertilization. So we stimulate the woman, and then we bring the ova and the sperm. We do the fertilization in the laboratory, and then we incubate it till the certain days, either day 3 or 5. I'll show you more. For the XC, we do the fertilization in our lab by ourselves, where we inject the sperm inside the cytoplasm of the eggs, and then so we do the fertilization by ourselves. Next one, please. This is like summary of the conventional IVF and XC. Next one, please. The first IVF baby was born at Oldham, Lancashire, by Patrick Steptoe and Robert Edwards and Jean Birdie, which was the nurse. That was on the 25th of July 1978, and Louisa Brown was the baby, which now have got 2 babies. So I'm just going to show how the IVF is safe. She already had 2 babies naturally without anything. Aiden and Cameron. They are 16 years and 9 years now. After the first baby was born, now more than 8 million child delivered worldwide by these methods, and they contribute about 5% of all births. Around 100,000 babies each year is delivered by this. So it's now we have this ART is more than 4 decades in the market, and we can say with confidence that ART is generally safe. Next one, please. While XC was initially started accidentally, actually, I worked with this lab back in 1997 in the lab of Andrew Van Stevenham. He's the director of the lab, and Paul de Vroy was the IVF doctor. Accidentally, one of the embryologists injected the sperm inside, and when fertilization occurred, that opened really a very big door for those who have severe male factor infertility. Next, please. This is the instrument where we are doing the XC. Next, please. You can go rapidly, because these are the reasons for XC treatment. Mainly, as I said, a severe male factor, or if we are using a frozen sperm and the sperm it cannot go by itself, or if you are using embryo testing. Next one, please. The success rate of ART is varies, but the overall, we tell our patient between 30 to 60%, sometimes 70%, and this depends mainly on the age of the woman. As you can see, if the woman is more than 44 years, the success rate is only 2%. If she's using her own eggs, and there is no legal age limit to do the IVF. The important thing is that we need to measure the AFC and the AMH and the FSH. The reason for this low success rate is the quality of the egg. We depend mainly on the quality of the egg and the grading and time-lapse monitoring. Chromosomal defects aneuploidy is higher in maternal age, and also the endometrial susceptibility and failure of implantation. Why I'm talking about this is just to show how important now a lot of people is doing, a lot of ACU units worldwide. They are collecting the egg, do the fertilization, and then they freeze these embryos and using them later on when they prepare the endometrium for so to improve the success rate. Next one, please. The ovulation induction we have in the market, the agonist and the antagonist. Now a lot of people would like the antagonist. Next one, please. I don't have time really to go through the details. To improve the take-home baby is that a lot of now embryology lab is growing these to the day 5, because then we knew that the before we used to do it at day 3 and 4, now at day 5. Assisted hatching, again, in case of advanced maternal age, high FSH, there are, because of the time factor, I cannot go through all of this. The thing is that with assisted hatchet, we need to be careful about the monozygotic twins is higher with the assisted hatches. And as I said, the frozen embryo transfer will be really a good option in order to avoid the ovarian hyperstimulation and to have the good success rate. Next one, please. Especially now with the cryopreservation, the vitrification, improvement of the methods of the cryopreservation, now we can get better result. And this is mainly a rapid freezing followed by rapid cooling. And more than 95% of the blastocysts can survive this vitrification result. And the best quality embryos are selected for freezing normally. Next one, please. This is for the, sorry, back again, please. For the freezing the sperms and the eggs, the eggs and ovarian tissue, as I said, the sperm and embryo freezing and thawing is more successful and easier than the egg freezing and thawing. But now over the last couple of years, really, the ovarian tissue freezing become very good, and I'm going to talk more about it, where we use it now for those who had cancer or using chemotherapy or radiotherapy. What are the prerequisites is to do screening for hepatitis B and C, HIV, and freezing done within 1 hour from the sperm production, multiple sample. This I'm talking now about the sperms. The storage is between 10 to 55 years. For the mature eggs freezing, the success rate now is 80 to 90% after thawing. And as I said, women at risk of early menopause or cancer can freeze their embryo. However, this has got several ethical considerations for social egg freezing, particularly if singleton, and the egg collection. We cannot, because she's a singleton, the egg collection has to be by laparoscopy, not by transvaginal route. Ovarian tissue freezing is the option, particularly for young children with cancer. Next one, please. And obviously, we cannot, with the children, we cannot freeze the eggs, so we need to freeze the ovarian tissue. Surgical retrieved sperm now in the market for more than 30 years, and we have either TZ or MESI, and with the aid of the microscope or no. This is mainly for obstructive or non-obstructive azoospermic cases, and it's really opened widely the door for severe male factor or those with severe azoospermia. Next one, please. We'll talk now about the BGD, or the pre-implantation genetic diagnosis. The embryo biopsy started in the mid-1980s, and it's opened the ability of biopsy the embryos, open a new era for what we call BGD and BGS, and I'm going to highlight what's the difference between these two. Next one, please. So the BGD started in 1990s as an alternative to prenatal diagnosis to avoid termination of pregnancy, and this is very important for us as Muslims, because the prenatal diagnosis, you diagnose mostly by the time the result comes, the result will be at 20 weeks or 18 weeks advanced age, and at this time termination of pregnancy might not be the option for them. And for that reason, the BGD was really a good for those in Muslim country or Muslim communities. Pre-implantation genetic screening, this is not to choose or the BGD, we use it in order to prevent genetic diseases, while the BGS is to improve the in vitro fertilization outcome in the infertile couple. The BGD, we use it for fertile couple, for a couple who had no problem with infertility, but they have either a genetic disease like thalassemia, and they have a lot several babies or children who died from the disease, and they want to prevent these diseases in their offspring, so they come as a fertile couple to do the BGD. BGS is an infertile couple, and we want to improve the outcome, the one we said 30%, for example. And this is normally for repeated failure for women with advanced maternal age. And the prenatal diagnosis, the withdrawal is that, as I said, it's after the pregnancy. It's either in form of CVS or amniocentesis. Next one, please. The embryo biopsy was started, as I said, 1980s in the lab of Lord Professor Robert Winston at the Imperial College of London. Professor Alan Handyside and Joyce Harbour were the one who created that, and I was really proud to do my research, and I worked with them for more than 7 years at University College of London with Joyce Harbour. Next one, please. So there were several ways of doing the embryo biopsy. We can either do the first polar body after the ovulation, or which will give us only the chromosomes of the eggs of the mother, or we can do it on the second polar body immediately after the fertilization, where we have the male and the female pronuclei, so it represents both the male and the female. Or we can do it at day 3 or 4, where we remove one at the morula stage. We take one blastomere, okay? But unfortunately that the mosaicism, which means these cells which we are taking, it might not represent of the whole embryo, and it might give us a high false negative result. For the next one, please. For this reason, it's much better if we wait, if the lab can grow our embryos into day 5 blastocyst, and then when the inner cell mass, which will form the embryo, we don't touch it, but the tracheotoderm cells, which will form the placenta, we can take as much as we want, like 10 to 12 cells, without affecting the embryo. Because remind you that these embryos, after we do the biopsy and send it to the genetic lab, that those who has no genetic disease, we will put them back and as an embryo transfer. So we don't want to damage these embryos. These at this stage is much better to have the DNA will be available, but the drawback of this is that not all embryos reach to this blastocyst stage, and it need really a good IVF lab before we apply BGD and BGS. Next one, please. The indication of the BGS, as I say, this is the limitation, and the mosaicism is high, as I said, and misdiagnosis could be 60% in the BGS. That's why when we talk about evidence-based, a lot of IVF doctor, they don't believe on the BGS. Next one, please. But the BGD, no, it's completely different story. The pre-implantation, what are the genetic testing we can do, whether BGD or for the BGS? We do it what we call FISH technique, which I'm gonna show you now quickly. and we can do the CGH or the comparative genomic hybridization. And more recently, this is now everyone. It's costly a little bit, but it's really now in the 2021. This is the best genetic test we can do. The FISH technique mainly we use to detect chromosomal abnormality. And the limitation of the test is that we only can do up to 5 probe at one times. And the commonest probe we use is the XY18. Why I'm mentioning this? We need to put the X and Y. So for when we come to the 6 selection, these we don't do it like for 6 selection, but the probe come from the factory as this, and we use this as our control to make sure that the probe is good. So the 6 of the embryos is readily available for us. For the whole genome amplification, the advances, I mean, you can see now from the coming slide how advances in genetic lab really improve our success on the BGD and in genome, especially with the genome finished back in 1990. Now we can have a chip that we can look to everything on that embryo by doing microarray chip for sequencing. Next one, please. If you can remind me with the time, how many minutes is for me, please, the moderator? I'll be grateful. This is the FISH technique. So you can see that the X and Y chromosome like this here. And then if we can see 2, we look at the chromosomal number. So we can diagnose like trisomy, like this one has got trisomy 21, the Down syndrome. So we don't put back these embryos. But a normal embryo like this, we can put it back. Next one. This is when we use more than one probe. The problem is that it's difficult to interpret the result, because sometimes we got signal splitting, and then we can have falsely saying that this is a 3 chromosomal pair rather than 2. Thank you. Next one, please. Next. This is the array CGH, which comes. This is really a good one, where we amplify the DNA from that cells which we talk, and then we look at the chromosomal number. The normal one, when we have, if we draw a line like this, this is the 46 chromosome, and this is the X and Y. Like for example, this is an XY boy, and this is a girl. It will look like this for us in the lab. So clearly and nicely we can see the 6 of the baby, and also the number and the normality of the chromosome as an euploidy. Next one, please. Because these are very important in order to know the Islamic perspective. We need to know whether these tests any false negative and positive, because according to this result you will decide whether you will put this embryo or you will not put it. Next one, please. This, by the way, one of the slides I made when I was working at UCL. For example, here we can diagnose monosomy on chromosome 2, which is incompatible with life. This is a trisomy for chromosomal 13, and this is euploidy for 20 for the whole, which is a normal one. Next one, please. With the SNAP microarray, I don't have time to go through it again. This is one of the methods which was used. SNAP microarray can detect genomic gains and losses. You can see that the gain is by the green and the losses is by the red one. So you can look at the whole genome, not only a single chromosome. Next one. So it's much better than the CGH. Next one. This is the difference between the SNAP and the array CGH. Next one, please. The next generation sequencing, as you can see, this is much better now. We can look at the whole genome, and it's being used in the human genome project. The only limitation is that they cannot diagnose Fragile X syndrome, and the allele dropout is about 5 to 10%. So we need to do linkage and analysis either side, and it's really costly. But now most of the company is trying to make it low cost. Next one, please. So if I want to do anything, the NGS is really much better. And you can see how clear and nice you can look at the gain and the loss of the whole genome much better even than the microarray chip. Next one, please. Next one. This is in the future. Hopefully, we will have DNA sequencing where each vertical lane nuclear base in the stretch of the DNA can be done. So the door is really going to be very, very open for the genetic testing for the embryos. Next one, please. These are some reproductive genetic testing. I'm going to speak about them in details next in the next slides. Next one, please. The common indication of the IVF and ICSI, as we said, for the infertile couple, whether male or female, or the unexplained, and now it's more than 4 decades in the market, the pre-implantation genetic screening, and this is again questionable, as I showed you, because of the whether it's effective or no. The BGD, or which is the diagnosis prevention of genetic diseases, mainly is being used for single gene disorder. 6 selection for medical and non-medical reason. I'm going to talk about these. Human leukocyte antigen matching and prevention of late onset diseases without 100% penetrance, and the cancer predisposition, especially BRCA1 and BRCA2 gene mutation, and ovarian cancer. And I'm going to highlight these more. Next one, please. This is like what we have what's called BGD consortium, and this is where they pool all the BGD cases from the whole world. And now the report in 2013, 50,000 BGD cycle was done and 10,000 babies were born worldwide from after doing the BGD. So we can say with confidence that embryo biopsy and putting back the embryo is a safe method. For single gene disorder, there is a long list, more than 300 genetic diseases now. We can do it, and remind you, these are all fertile couple. We can also diagnose chromosomal rearrangement in the fertile couple, and it can detect the cancer predisposition BRCA1 and 2. And I'm really proud that at UCL, they were the first genetic lab in the world that they start this BRCA1 and 2. Next one, please. Next slide. Indication for 6 selection. This is really important, either medical or non-medical. Medical to diagnose and prevent severe X-linked disorder. Non-medical, which is, we call it social sexing or family balancing. Next one, please. The method for 6 selection, we got as well non-medical method like diet, timing, intercourse, vaginal pH, or the medical methods, which is preconceptional. We have 2 methods, either the sperm sorting or through the BGD. And we got the prenatal diagnosis, which we don't like it because it's going to too late and we need to have a termination of pregnancy. Next, please. These are the success rate. As you can see, if we do nothing for 6 selection to get the desired 6 is 51%. If we use the sperm sorting and diet is 70%, but the only method which is really an accurate one is through the BGD. Next one. For 6 selection, as I said, diet, I don't have really time to go through it. Diet, time, the intercourse, vaginal pH. The quick thing is that if you have a boy, you need to make the vaginal pH alkali. If you want a female, we make it acidic. If you eat magnesium, diet high in magnesium and calcium, you will have a girl, hopefully. But as I said, the success rate is not very good. It's not very accurate. It's only increased by 5 to 10%. But this is allowed in Islam. By the way, we will talk about the perspective later. The medical method, the sperm sorting, is using the flow cytometry, and this is the accuracy is only 60 to 70%. It's based mainly on because the female or not female, sorry, the X chromosome, the X chromosome of the sperm, they are more dense and they are more heavy. So when they put it through the flow cytometry, they can separate it, but it's not 100% separation. We can ensure the woman that 73% success rate if they want a male baby, and 80% if they want a female baby. Next one, please. With the BGD, which is this is more invasive and costly, as I explained before, it's need a lot of work. The ovulation induction is intensive, and it's really having a lot of maternal morbidity. Next one. I got only 2 minutes, so let me see what I can do. Probably I can finish the other rest of the lecture in the open forum. The medical method for sex selection, as I said, by the chorion villus sample or the amniocentesis, and these are having the problem of termination of the unwanted sex if it's there, and this is maybe not good for Muslims' world. Next one, please. IVF BGD is remain the best method, but it has got a drawback. Next one, please. The ethics of sex selection, it's very important to distinguish between the indication, like medically indicated, it's allowed, but non-medical is very debatable, even in the Western country, not only the Islamic country. But there are, as I said, if we are doing infertile couple and then the sex of the baby is readily available, then maybe it's allowed, and there is no problem with that. Next one, please. For the HLA matching of saver sibling, this is the aim, is that we do, if the couple has got a sick baby that need stem cells, and this will be needed for all his life, and they need they might do an IVF to choose an embryo that matching the HLA typing of this sick child. So this new baby who's matching, they can be used long life to have stem cells from them in order to survive the sick baby. And this is a nice movie, was by on this method called My Sister Keeper. I really would like those who's interested to look at it. It's really nice. Next one, please. And either we can do it having a child with this, or we some people now, but it's not really in the market, is that to have an embryos, and these embryo you can produce stem cells from them and use the stem cells rather than having a child. This one has got 3 ethical questions really and concern even in the Western country, that this child may be because is it our right or the rights of the parents to choose to have the biopsy and use this child who's an incompetent minor for this bone marrow aspiration? Is it their right, and where is the child rights? Can the parents decide for the interest of another child or sibling? Next one, please. Is this baby, the coming baby, will be liked? For example, if the diseased child died, are they gonna like him? How this child will be feeling? Is it like I only my parents bring me to this world? If I'm not same matching of my brother or sister, they might not bring me to this world or choose me for the embryo transfer. So these are, next one please. And it really need a lot of support, especially for this healthy child who's helping the sick one. The process is complex and demanding. Some parents cannot support sick child. The success is less than 10%, and the cost. And sometimes, you do the test, and in order you need to choose a healthy, normal baby, not sick as his brother or sister, and also matching. Sometimes you find 20 embryos, none of them is matching. What you will do with these embryos? Are you going to throw them? So all of these questions is really important, and we need to know it before we decide whether this is applicable or not in Islamic country. Okay, welcome back. We were talking about the BGD for the HLA testing, some ethical issues. And as you can see, the article of the European Convention on Human Rights and Biomedicine of the Council of the European prohibit creation of embryos for instrumental use. So the creation of human embryos for research purpose is prohibited. Acceptance to use surplus or spare embryos remains after IVF or IVF BGD for research. The moral status and protection of the embryos, and the risk and IVF super ovulation and the cost. So even the Western country, they are not getting with the using of BGD HLA testing for the creating or having a baby that matching the sick child. So not every country they agreed for that. And here, okay, next one. Probably with the Islamic perspective, I'll talk about more on that. So now we go to the prevention of late onset diseases through doing BGD. The ethical debate here is the advocating reproductive method is cost. The limited chance of success, long-term outcome is unknown. And the important thing is that maybe even if you choose or if you find the embryos which carry the genes that cause, for example, the diabetes, it might not, if that embryo was put again, he might not develop the diabetes, because the disease is not 100% penetrance, means not everyone who had the genes will have the disease. So this is really an important aspect. We need to look at it when we come and see whether this is agreed in Islam or not. Next one, please. BGD to prevent cancer predisposition, as I said, BRCA1 and 2 mutation. By 2012, 140 cycle done with 70 couples for this, and 43% of 717 embryos carry the BRCA genes was found. And the pregnancy rate was about 41% from the fresh embryo transfer and 23 from the frozen. So all of these things we need to tell the couple by good counseling is very mandatory, because people think that, look, we have an advances in ART and BGD and it's going to be the solve of all our problem. No, it's not like that, because even if you start with IVF, say if you have 20 embryos, probably 18 out or 15 out of them will be fertilized, and then after the embryo, because it's a lot of stages will go through. So if embryo biopsy was done, not all of them will be again survive. And then out of these whom we biopsied, how many of them will be free from the disease? Sometimes we ended with only 2 or 3 embryos is good for the transfer. Next one, please. So all of these has to be counseled to the woman. The epigenetic, these are my slide when I was doing a research at UCL. I was doing staining for the DNA methylation and the epigenetic pattern. And I found as just a summary that yes, there are some changes, epigenetic changes with the IVF culture in the DNA methylation, which is really important for the gene expression. Next one, please. So we need to put all of this in our mind. Now we start about Islamic bioethical perspective and reproductive technology. Next one, please. Next slide, please. Yeah. So rapidly advancing information and technology in human genetic raise the intense ethical concern. Response of these different between societies, social, culture, religious, philosophical, and political background, as well as the moral status of the embryo and beginning of life. And here I'd like to stress that, like Roman Catholic, in their religion, the life begins at time of fertilization. Accordingly, so at the time when the egg and sperm, accordingly, it's not allowed to do, for example, BGD or embryo biopsy for the morula or for the blastocyst stage. The only thing allowed in the Roman Catholic is that to do it as polar body. That's why you will find none of us is doing polar body biopsy except in Rome and in Italy, where they really putting forwards this legalization. And in Islam, the moral status of the embryos are considered as cells. And the life start in Islam when the soul is inflated at 20 weeks. However, the embryos are still respected in all the stages. So genetic testing, so we need to put this in mind when we think and look at the Islamic perspective. Genetic testing directed towards the benefit of expectant parents and or the child to be born and improving the result of IVF. Next slide, please. Fatwa and legalization, I was publishing in 2012 along with Joyce Harbour this paper. I hope that if you have time, if you can look at it, it's really explain a lot how we are doing the fatwa and how legalization in Saudi Arabia for the BGD. I wouldn't have time to go through every bit on it in my presentation, but I'll highlight the important thing. So fatwa, to start with, fatwa is not binding by law, remain discretionary and may change with change in evidence. There's a different opinion or fatwas. The final decision is the legal authority in the which need to be respected, as Sheikh Al-Maymani said. Every Islamic country has its own legalization. For example, in Saudi, the legal fatwa issued by the General Presidency of Scholarity, Research and Fatwa, which is Dar al-Ifta, and the Hayat Kibar al-Ulama, Saudi Council of Senior Scholars, or I refer them as CSSS, or the Senior Ulama. Next one, please. The main source of fatwa in Islamic world, we have, as I said, in Saudi, we have along with the General Presidency of Scholarity, the Islamic Fiqh Academy, IFA, Organization of the Islamic Conference. And this is really represent the whole Islamic world, but it's based in Mecca, Al-Mukarramah. And we have also the Islamic Fiqh Academy in India. And we have the Islamic Organization for Medical Science in Kuwait. And also we have the European Council for Fatwa and Research, which cover the whole Europe and South and North Africa. And we have the Muslim World League in Europe, which is based again in Jeddah. And we have the Dar al-Ifta, which belongs to Al-Azhar al-Sharif in Cairo. Next slide, please. And here, as you can see, the percentage of Muslims in the Islamic world. The Islamic perspective, Islam encouraged marriage and reproduction, respect the families to construct earth, preserve the offspring. It's coming after the religion. The five important thing is that ad-din wal nafs, religion and self, and after that coming preserve the offspring, then after that the mind and the money. So treatment of infertility is encouraged in Islam, and the ART is allowed in Islam as far as it fulfill. When I talk about that, is IUI, which we said about the internal insemination, in utero insemination, the IVF and the ICSI, as far as it's fulfill the following. It should be within the framework of marriage. The contract of marriage has to be valid during any procedures of the ART. No third party, only wife's egg and husband's sperm used in any procedure of ART. And if the couple, husband or wife, had frozen eggs or sperm or embryos, they can use them only while the marriage contract is valid, not if they divorce or there is a death of any of them. Excessive caution is recommended. An ART is preferable to be done by a reliable Muslim doctors and lab technician as well. As you can see from the whole slide I showed you before, how these are delicate and complex things we are dealing with, and it need really a lot of caution. The extra gamete eggs, sperm, embryos after ART has to be discarded. These are the fatwa from all of these organizations. I don't have time to go through them, but these are all the organization which agreed on this fatwa. Next one, please. Use of frozen and extra embryos after IVF. The Islamic Fiqh Academy, suspensory of Muslim World League, in his 17 session, that was back in December 2003, along with the Organization of Medical Science in Kuwait. They make a fatwa that extra embryos from ART that donated by the couple is allowed to perform research on them or used to get stem cells from them for treatment purpose, but never place it in another woman for the purpose to get pregnant. And these are the fatwa in Arabic. Next one, please. We'll talk now about fatwa on sex selection. Next, please. This is the fatwa from the Majma' al-Fiqh al-Islami. I wouldn't go by Arabic. I'm translating it in English. Next slide. That was in November 2007 issued by the Islamic, next please, by the Islamic Fiqh Academy. Okay, so the sex selection using non-medical methods such as diet, change of the pH and vagina, and timing of relationship is allowed. However, which I said is not accurate, is about 60% only success rate. While sex selection using medical method, which we are talking about sperm sorting, IVF and BGD, which is the best for medical indications such as preventing genetic disease that affecting one sex, is allowed in Islam and by that fatwa, and it's encouraged, in fact. Provided that we need to have a specialized committee with 3 respected Muslim doctors to prepare medical reports and recommendation that this couple need to have a sex selection through the BGD, and they agreed by the specialized religious committee. Sex selection using medical methods, these 2 methods, but is not allowed for non-social medical indications such as social sexing. Next slide, please. Another fatwa comes from Al-Azhar, from Dar al-Ifta, regarding this. So everyone is agreed about the first 2 fatwa, but when it comes to the social sexing, Dar al-Ifta, the International Islamic Center for Population Study and Research at Al-Azhar University in 2000, they did a workshop, and what they conclude that the social sexing is disfavored in principle, but it was resolved on particular merits. They said that social sexing is condemned on the ground, their application to discriminate against female, reproducing prejudice against the girl child, and social devaluation of the woman. They only agreed that social sexing can be done through BGD, may be acceptable if the wife has born 3 or 4 daughters or son, and it was in her and her family's best interest for another pregnancy to be her last. BGD approved to satisfy the sense of religious or family obligation and save women from risk-laden of pregnancies. And these are published first in 2012 and also 2019. Next slide, please. So we have 2 fatwa regarding the sex selection. Again, this is a nice publication from Jamal Surur. He's the president of the ISCBSR in Al-Azhar. He also, in his paper, said sperm sorting, IVF, BGD, should not be used for selection of the sex of the first child. The same meaning of the fatwa means if the couple come and they don't have any children, they cannot use BGD. It should be having at least 3 children from the same sex. It's only applied, as I said, only 3 or more. Service only provided after proper counseling with the reproductive medicine physician, genetist, social scientist, and psychologist. As I said, we need to explain to them, because people, they think BGD, IVF is very easy. It's very successful once they go and put their money, which might be really expensive, and they might spend years and years in putting this money in order to have one. It might not be successful, and they need to understand maybe all their embryos from the unwanted sex, and then what they will do. They need to know all of this and discuss it with them. Next slide, please. Next slide. During infertility treatment, as I said, the couple is already doing that. So there is all of this precaution. We don't have it. I think in this situation, most of our scholars will agree if it provided that the chosen 6 embryos is having the same grade and good and success rate as the other. Next, please. Next, please. Thank you. So the ethics of IVF and BGD, as we said, the Islamic Fiqh Academy Jeddah resolution in 2007 allow BGD to identify the healthy embryos, not carry the affected genes. So BGD in principle, again, Islam is encouraged it, and the IFA in 2007 agreed that they can have it. Although we need to explain that IVF is stressful to the couple, BGD is inconvenient, expensive, emotionally and physically draining. We need to weigh up against prenatal diagnosis, whether this is the case for IVF for social sexing. As I said, most of our scholars will not agree for that. Next one, please. Now we finished from the 6 selection. We'll talk about the freezing of the gametes. What are the Islamic perspective about this? The Islamic Fiqh Academy in Jeddah in 1990, the resolution, this number, they said that we need only to prepare the required number to be used in embryo transfer each time. They are against freezing the embryos. We need to avoid producing extra embryos. And in case there is an extra embryos, we leave them in lab to die. Freezing is not allowed because they were fear of mixed lineage and human errors, even if it's 1 in 1,000 or 1 in 1,000,000. But unfortunate, as I showed you from medical views, that we really need this freezing. And luckily enough, now there is a fatwa. Next slide, please. So most of our lab, Islamic embryology lab worldwide, they were using the cryopreservation despite that fatwa back in 1990. Luckily enough, in January 2019, we had a fatwa from the Saudi Council of Senior Scholars, this resolution, which was the meeting in Taif and then finished in Riyadh, where they agreed now it's allowed to have cryopreservation of ovarian tissue or unfertilized egg from cancer patient. To preserve the offspring, and fertility freezing is allowed in order to transplant the ovarian tissue later on after the lady is cured or treated from cancer. The transplant is done only to the same woman, no third party. And extra tissue should be discarded, not needed anymore, failed to transplant or death by the supervisory committee. Informed consent for the woman, especially if we are dealing with a child with cancer less than 18. We need to ensure, these are the precautions they put, need to be, the Muslim doctor has to, or the center has to fulfill it before they allow the procedure. They ensure that no mixing of the sample or patient, whether at the stage of removal of the ovarian tissue, at the time of freezing and the replacement back. Supervisory committee legal member should be a legal member from this committee. Next slide, please. These are the fatwa, which come in 1440, just 2 years ago. Next slide, please. Okay, freezing it for single unmarried woman to preserve her fertility. This is again an ethical debate. The eggs, people saying that the eggs belong to the woman only, so they favor it. We knew that there is a lot of ladies who married late, for whether from Allah or because they want to study, complete their study and career. So they want, because of the late marriage after 40, because as I showed you, remember, if you do IVF in a lady who's 40 and 44, the ovarian reserve will be almost very little, and the success rate may be less than 1%. So as a solution, some women, they would like to freeze some of their eggs at 20 years, and they keep it in case if there is late marriage. And then the risk of this, before we ask whether it's allowed medically, as medically indicated, we knew that to get pregnant at age of 45 or 50s, there's a lot of risk of late pregnancy. And also we need to think of the children's rights to have their parents with them, because maybe this parents or this old woman might die, and then that child might live as orphans. Difficult to raise a child at different thinking with different generation. So we need to think about all of these issues, because now, unfortunately, after the CSS allowed freezing the ovarian tissue for cancer patient, a lot of women, they are coming who is not having cancer, but they want to preserve their fertility. We knew that in Western country because they allow for a third party. So even women at this stage, 45 or 50, they can go and have an egg from their sister, from their mother, or from anyone who's relative to them, and they can have a success rate. But in Islam, we cannot do that. Next slide, please. So how many minutes left to me? Because I need really to go quickly. A few slides anyhow. Legalization, worldwide, the Human Fertilization Embryo Authority is really an important one. In Italy, there's a social use of BGD is prohibited. As I said, in France, each request has to be agreed. In China, National Commission, this is the one which do the control. In India and Netherlands, BGD only with specific license. In USA, lack of any institution that make state or federal law for the BGD. Next one. So this lead, as you can see, fertility tourism, that cross-border reproductive care, because in USA, there is no legalization. So every woman like from Italy or from anywhere of the world, they can go there and do whatever they like. Next slide, please. This is the paper which I talk about it. Next, please. Legalization of ART in Saudi. In Saudi, we have the Saudi Ministry of Health, MOH, issued the first code of practice for assisted conception unit, embryology, and infertility. This was updated in, next slide, please. Next slide. It was initially in 2006 and then updated in September 19. It has 6 chapters with 41 subdivision. I don't have time really to go through this. Next slide, please. And these are the important section which regulate the code of practice and the work of ACU based on Islamic fatwas from the CSS. And this is an important that every unit in the kingdom has to follow fatwa from the CSS mainly. Next slide, please. Because this is our official fatwas. There are some changes in the code between 2019. For example, the freezing now is removed. The one which was not allowed before, freezing now is allowed. Next slide, please. And this is an important thing because during the changes, the new practice of code, they said now, as I said before, it's not allowed if the husband or died, for example, to use any frozen embryos for the woman to be put. However, in only one situation, the code stated that if the husband has good brain death, but he's already agreed before he went into that brain death and he got spare embryos, maybe the wife can put it back, provided that she had a special allowance from the CSS. Next one, please. So to conclude, ART is an important, I have got only 2 slides to conclude quickly. ART is an important revolution in medicine, now more than 30, 40 years, and gave a hope for millions of couples whose childless or delayed fertility worldwide. It's allowed in Islam, provided it's fulfills certain criteria to preserve the lineage. BGD for medical indication is encouraged in Islam to have a healthy offspring and avoid genetic diseases in couples whose known carrier. Sex selection in principle is allowed in Islam using natural way, and I stress on this natural way. Social sexing using medical assistance such as sperm sorting and BGD is not allowed by FAA, allowed only by the Azhar in case if there's 3 or more children from the same sex. Freezing during ART is allowed on special precaution to avoid mixing of the sample. Last slide, please. Advances in egg freezing by vitrification allow successful egg freezing, and this is really good for women with cancer to preserve their fertility. We need an urgent fatwa in some advanced indication because there is no fatwa whatsoever about this. HLA matching sibling, prevention of late onset disease, prevention of some cancer, ovarian vitrification for normal girls who's afraid about late marriage. Social sexing in some circumstances to preserve the family integrity and avoid divorce, extracting sperm by MESA for men with brain death before they are winning of the ventilator to perform XC or ET for the wife and use their frozen sperm and embryos in the ET of the wife in the embryo transfer. And I'm really so happy to make this invitation. We are planning at the Saudi Society for Studies in Medical Jurisprudence to plan to conduct 4 forums to discuss this urgent fatwa which is needed next year, inshallah. And before we come out and write our recommendation to CSS to issue the fatwas. And if anyone is interested to share in these 4 forums is more than welcome, and I'm going to accept the abstract by December 5th to my email. And thank you so much. Next slide, please. Thank you very much.